Hello, everyone. My name is Dr. Jingsong Zhang. I'm a medical oncologist at the Moffitt Cancer Center, primarily focused on treating prostate cancer. I'd like to thank Formatics for the opportunity to bring together three of my colleagues, very experienced medical oncologists in the Tampa Bay area, to discuss about management of prostate cancer. So I asked them to introduce themselves.
I am Dr. Nuruddin Jooma. I'm with Florida Cancer Specialist, medical oncologist, and hematologist.
And I am Jad Chahoud. I am a GU medical oncologist at Moffitt Cancer Center.
And I am Vikas Malhotra. I am with Florida Cancer Specialist in the Spring Hill location.
Yeah, we actually share patients, mutual patients, talk to each other on a frequent basis. So today's topic is metastatic prostate cancer. So we'll start with castration-sensitive prostate cancer. In the past decades, there are like a couple of phase 3 trials to show the benefit of upfront combined androgen deprivation therapy for subset patient. There's benefit for triple therapy as well. So I think I'd like to get your input in terms of when you're facing a new patient with metastatic castration-sensitive prostate cancer, let's say the Novo metastatic disease. So how do you make the treatment decision whether this is a candidate for combined ADT or this is something you will offer triple therapy? You want to start first?
Sure. So the extent of disease, usually a lot of time these patients will present with some sort of symptoms or symptomatic disease burden. Also looking at the age, the comorbidities to determine if they're a candidate for doublet or triplet therapy. Based on the Arsenis data, I tend to prefer more the triplet with docetaxel and darolutamide and androgen deprivation if they have the higher disease burden. Now, if they're elderly, which we tend to have a lot in Florida, and or have comorbidities, then doublet therapy preferably, because to maintain their quality of life as well.
Yeah, there's some recent data. I think JAMA Oncology look at the elderly patient population. There's increased cardiovascular event for patients like more than age 75. This year's GU ASCO, there's a meta-analysis look at the survival benefit for people aged more than 75, definitely diminish, with doublet treatment. I think, just treat the patient as a whole, particularly in Florida. Lots of these elderly patients have comorbidities. Right. So, Jad, do you want to add something?
Yeah, as we were talking, prostate cancer is an interesting disease because it's very heterogeneous. It's a combination of now molecular imaging, molecular data, and then the patient, and it allows us to tailor the more of a patient-centric decision making of doublet versus triplet. Sometimes using multidisciplinary teams for oligometastatic de novo patient with SBRT or therapies in addition to an ARPI plus ADT instead of a triplet therapy up front. Most of the times we could start with your doublet as Noor was mentioning, and you'll get in the NGS, and if you see any of those high risk hits as well, in addition to the high volume, that may push you more toward starting with taxol up front with a triplet therapy.
No, I completely agree with both of my colleagues' comments. So it's in the eyes of the beholder. When you see and meet the patient, the most success I've had is with my patients in the 50s and 60s. 70s, I'm very careful. Occasionally you'll meet somebody very fit at 70, but I've had less luck. And we see a lot of patients, of course, mainly in 70s and 80s. So those are not good candidates for triple therapy. But I've had a lot of young, fit patients, high volume disease, visceral disease, rapid turnover, doubling time is very short. Those are people I would definitely offer.